Perfect. Thank you very much. So kind of our agenda today is to talk about the expansion to all SUD health home model. We're also going to do a rate determination process so you guys know what the process will be, and then do an overview of the SUD health home service model and requirements. Some key points that we would like to make sure that you guys are aware of is that Main Care Benefit Manual currently includes SUD treatment and case management through community-based service providers. So as you can see, we listed some for you: targeted case management, outpatient services, medication management services, medication-assisted treatment, opioid health home, intensive outpatient services, and community care teams. And then we have residentials, that is clinically managed low-intensity residential services, clinically managed population-specific high-intensity residential programs, clinically managed residential services, medical monitored inpatient programs, and then we have inpatient. So inpatient is psychiatric residential treatment facility services. This model is based on the OHH model, but will adapt and expand to all SUD diagnosis within eligibility. The only two that will not be in there is tobacco and caffeine. This additional service will provide patient-centered services for SUD treatment, including full wraparound intervention, comprehensive case management, counseling, and medication. And then as you can see on the other side of your screen are health home services. So anybody that's new to OHH model, we have health home services built into all of our health home models within Main Care. So it's comprehensive care management, care coordination, health promotion, comprehensive transition to care, individual and family support services, and referral to community and social support services. I just want to note, kind of remember that, because when we go through some slides in the future, we'll talk about our health home services. So when we talk about the health home services, those will be the services that we're talking about. And then we'll go into policy development process. So completed steps that we've already done is engage with partners like yourself that are on this call. We researched other state models. We coordinated with the Opioid Clinical Advisory Committee on withdrawal management guidance. Our current steps right now is we're reviewing rate assumptions and rate model, and we're refining service model. And then our future steps are rulemaking and state plan amendments and implementation of the policy. Now I'm going to hand things over to Jessica.
Thanks, Kaylee. I'll take a minute to talk about the rate reform process, which might be new to a lot of you on the call. This is a standalone law we now refer to as the rate reform law. It's Title 22 MRS subscript 3173-J, and it was enacted in 2022, and it establishes a process for the rate determination, which includes the following steps that are listed here: annual updates to rates benchmarked off of Medicare and other payers. For non-benchmarked rates, the department annually develops a schedule of a rate determination for the upcoming year, and rates not being redetermined per the schedule receive an annual cost of living adjustment. Our process also ensures a review of relevant state and national data to inform rate amounts and payment models. It ensures a formalized, clear, and transparent process, which is a public notification of an initiation notice, and we do presentations like today. And we also include, the public has an opportunity to do official written comments on the draft rates, and the department will respond in writing to those comments, and they are posted on our website. And then it also established a rate system subcommittee of the MAC, the Main Care Advisory Committee. And there is also an establishment of the Technical Advisory Panel, which advises on related technical matters as appropriate, reviews an annual schedule of the rate determination. The panel does meet twice a year unless the commissioner convenes it more often. Next slide, please. this is a model of how the rate determination process works. So it starts off with the kickoff, which we're doing today. Then, as Kaylee was speaking of, there's data collection, there'll be a rate model development, there'll be a presentation of the rates, an opportunity to comment in writing, in which the department, as I stated on the previous slide, will respond in writing and post those on the rate reform website. Take that into consideration if there are any changes to be made to the model based on those comments and feedback. Then there'll be a final rate that will be implemented and posted. And then it goes into the rulemaking and adoption process.
Perfect. Thank you, Jessica. Now we're going to go into an overview of the SUD Health Home expansion. So we'll start off, just for your knowledge, with explaining what the Opioid Health Home program is now. And then my coworker, Allison, will take over and explain to you of what we're hoping it's going to look like in the future of what we've done for research. So Opioid Health Home Foundation. So as you can see on this slide, the Opioid Health Home is a per member per month base payment. In order for you to be eligible for the Opioid Health Home program, you have to have an opioid use disorder and another chronic condition, or at risk of having a second chronic condition. The Opioid Health Home is an organization that provides team-based approach to care for individuals receiving office-based medication-assisted treatment. And then some other services that they work very closely with are behavioral health, HIV care, primary care, and social service agencies. So they coordinate very closely with them to make sure the members' needs are met. Also in the Opioid Health Home program, we do pay for performance. So people that are on this call that are part of the Opioid Health Home program, this is something that you guys are familiar with, but someone that's not familiar with it, we would like to kind of explain to you what the pay for performance process is, and so you know what the measures are currently. Right now, what happens is 4% of the OHH payment is at risk by a withhold arrangement. So what that means, for anybody that's not aware, is we automatically take 4% out of the rate when providers are paid. They could potentially earn back a greater amount based on performance. So what that means is we have two baseline thresholds. So we have a regular threshold and then an excellence threshold. So if a provider meets that excellent threshold tier, and there's a provider that falls under the threshold, there's a pool of money that is divvied up against all the providers that met that excellence threshold. And we provide quarterly reports to all OHH providers. Right now in current policy, every provider has at the 6-month mark, so they'll get the 4% back if they meet that threshold. We do allow for a rebuttal period for our providers in case there's information that we didn't get from claims data or information that we might have missed. Right now, the current measures are continuous medication-assisted treatment, percentage of patients who have at least 100 days of continuous treatment, determined by consecutive months of appearing on an OHH practice roster. Then we have primary care, so a percentage of patients who have at least one PCP visit in the previous 12 months. It does not have to be a physical. It could be anything from an earache to going to see the doctor for something else. Again, I just want to make sure that you guys are aware it does not need to be a physical. And then we have a self-reporting measure on employment and engagement. So providers in the Trezzo system report every time they go in and do a continuous day review or initial review, they report the information on the member's employment status or engagement status. This is a percentage of patients who report being employed, looking for work, attending school, mothers or fathers caring for children, and doing volunteer work. So there's a range of different things a member could meet those requirements with. As you can see on this screen, it's a overview of what current services and bundles that the Opioid Health Home service offers. So someone that is in induction, stabilization, maintenance, IOP level of care, they are required to have at least a minimal visit with an MOUD provider once a month in our billing month. So our billing months, for anybody that's not aware, goes from the 21st of one month to the 20th of the following month. With this being said, the rates do have it built in that a provider can see them more than one time per month, because we understand that someone that's in IOP, induction stabilization, might need to see the prescriber more than one time per month. And even someone in maintenance might have a rough month and they would like to see their prescriber more than one time, and that's fine. So the requirements that we have are minimal requirements. So a patient can see a team more than what is the minimal requirement. For counseling, we have different requirements depending on the level of care that a member's in. So it can go from as little as one time for 1 hour a month to IOP, which is 3 days, 3 hours per week. So that's a lot different in range of counseling. And then we have our team-based health home services. So those health home services that I spoke about in the earlier slides, we are requiring that all members have at least one of those health home services a month. So it doesn't mean that they only have to have one. They can have multiple visits. It can be done from any of your team members that are on your OHH team. So we have and Allison will talk about this later on, but like peer recovery coaches, patient navigators, nurse care managers, all of those members can meet with a member to complete this health home service requirement. And now I'm going to hand things over to my coworker, Allison Weeks, and she will talk about the new SUD health home model.
So we have heard a lot of really positive feedback on our opioid health home model. So we said, well, what if we look at expansion to all SUD services? This model is working well, so let's look at ways that we can make it more encompassing for individuals that have other substance use disorders. So we met with our OHH providers and various stakeholders groups to kind of hear what would they like with this new model. And some of the things we heard was having some flexibility with the treatment plan. If you are if you're at a level of care where you don't need medication, then really medication-assisted treatment intervention should not be a part of that treatment plan. One of the things that we heard over and over and over was if we're looking at expanding SUD services to encompass alcohol withdrawal or alcohol use disorder, ambulatory withdrawal management needs to be a component of that. So we looked at ways to integrate ambulatory withdrawal management, allowing for staffing and team flexibilities. Various agencies don't necessarily employ all of the providers that we will talk about shortly. So we looked at ways that we can make this as encompassing as possible, but still allow flexibilities for different makeup of agencies to provide these services. Changing the language for urine drug screens to allow for different types of testing. Making sure that we had expanded health screens and allowing for disease management, because, you know, individuals with an active substance use disorder oftentimes don't necessarily take care of their physical health. So that's important to tie into this and allow those services. Contingency management, we know, is the gold standard for treating stimulant use disorder. And so there's a lot of interest in figuring out ways to have braided funding for incentives. Providers also said, hey, if you're asking us to step outside kind of our current lane of opioid use disorder and asking us to do alcohol withdrawal management, that we might need some additional trainings and clinical consultation support so we can feel comfortable taking on this new kind of treatment components. And then also components that address SEI for other substance use disorders other than OUD, such as our main mom program. And while we tried to include all that we could, contingency management is something that we're continuing to explore. We are working with the SUD learning community to figure out ways to set up echoes and trainings and just consultations for providers to learn more about alcohol use disorder and ambulatory withdrawal management, or benzodiazepine use disorder and supporting an individual through withdrawal for that. In terms of expansion of main mom, that is something that is on the table, but probably is going to come down to in the future. It's not going to be a component of this. We hear you, and we have that on the list of, ideas for improvement in the future. Essentially this SUD health home expansion, we recognize is not necessarily solves all of the issues, but it's definitely a huge step in the right direction in providing full wraparound support. So that's our feedback. And now let's talk about ways that we were able to integrate that. So if you look at the staffing requirements for an opioid health home, you have a clinical team lead, an MOUD prescriber, nurse care manager, clinical counselor, peer recovery coach, patient navigator. And we recognize that, some agencies might not have all of those. So in the current model, it allows individuals to serve multiple roles when appropriate. And then if you look at our SUD health home model, our new model, it's essentially mirroring that same type of staffing with the addition of the withdrawal management RN. Because with that additional component added, we needed to have somebody who would be able to provide that level of care. And you see that there are prescriber, clinical counselor, withdrawal management in blue. Some of these positions might not be required based on the level of care that your agency chooses to provide. You might be able to go, hey, I can do A, B, and C, but D, I just don't have the staffing for that. And that's okay, because again, we heard loud and clear, give us as much flexibility as possible so that we can treat as many individuals as we can based on our staffing. And so several individuals can serve multiple roles, and some of these positions might not be required based on the level of care. So let's talk a little bit about what are the level of care. So we have the proposed medication tier, which those of you who are opioid health home providers will be like, this looks kind of familiar, because essentially what we did was we mirrored the opioid health home with the addition of adding the nursing. Because when we look at that withdrawal management and that withdrawal assessment period, we want the nurse to be there to provide that coverage, that intervention, that scope of care. And so we basically just took the opioid health home, popped in nursing, and here we have it. This tier is designed for individuals that have an SUD, that have an FDA approved medication for interventions, or an individual that has an SUD that says, you know what, I maybe need some medications for my depression to help me recover successfully. So we really heard loud and clear giving flexibility, which is why we said, hey, if we do it this way, then we can really do that wraparound co-occurring, meet an individual's mental health needs, their substance use needs, to really set them on the best path for recovery. So next slide. Talking about one of the feedback we got was, hey, sometimes people don't need medications for their addiction treatment. So we said, well, okay, we'll look at that. And how do we do that? Well, we took the medication here and said, we'll take out the medication plus. If they're not getting meds, they don't need that. Induction, they don't need that, but they would still need withdrawal assessment, the IOP intervention, stabilization, and maintenance. And so essentially this tier allows for an individual that says, hey, I don't want medications, or I don't, maybe there's not a medication that is an FDA approved to treat my substance use disorder, but I still want all of the other wraparounds. And so this tier is essentially just like the medication tier. It just removes the medication components of it. So really we put in as much flexibility, but allowing for that full wraparound. Those health home services are there, and you can see the counseling depends on what tier they're in, how often they need to meet with that individual. But we really try to build in as much flexibility as possible. And then if you have somebody that's like, hey, I already have an SUD counselor, so I'm getting services under Section 65, or I'm going to the opioid treatment program and I have my methadone, so I don't really need all this other stuff, but I need some assistance. And so with that, we have our next tier, which is formally known as the methadone level of care for those of you who are currently providing opioid health homes. And this care really is for those members who are receiving methadone or services under Section 665 who also would like some of those health home services to just help them kind of continue on their path to recovery. And so that's what this tier is. Next slide. So to become an SUD health home provider, there's quite a few requirements. Must be a main care enrolled provider and be approved as an SUD health home by the department. And because we really recognize that substance use often doesn't occur in a bubble, you have to be co-occurring capable. We're really trying to drive for that full integration of care for an individual. So must be a community-based provider located within the state of Maine, have an approved team of those provider set that we talked about before based on the level of care that you choose to provide. And because again, we're really looking at connections to care, you have to have those process procedures and the referral of what am I going to do if this individual needs a different level of care than I'm capable of providing. We want to ensure that those transitions are as smooth as possible. And again, one of the things providers said was, hey, we want learning opportunities. So if you're going to provide the learning opportunities, we're going to make them mandatory for you to participate in some of those technical assistance and educational opportunities. Highly encouraged to utilize an EHR. It's one of the easiest ways to kind of keep track of everything that you're needing to do. Next slide. And then there are some specific health home requirements that are just part of the core standards. And that's really looking at team-based approach with demonstrated leadership, because we're trying to build this structure of care that really looks at an individual as an individual and not pieces, parts of a diagnosis, and build that full inclusion. So we want to enhance access so that if somebody's ready for care, they can get that help. Integrated care, behavioral and physical health integration, because again, we can't divide an individual by their physical or health conditions. They're one person. And so the more encompassing we can be, the better. Connections to community resources, because again, we're trying to make sure that SUD treatment occurs in a continuum. So the more that we have connections to the continuum of care, those wraparound services, those additional supports, we know the more successful an individual is going to be. In integration of health information technology, because it's just one of the easiest ways to really keep track of everything that we're doing and to make those connections. Next slide. And again, if you have a health home member who's under the care of a perinatal provider, then you have to have a relationship with them. If they have a primary care provider, you have to have a relationship with them, because the idea is we're really trying to provide a team-based approach to interventions for an individual. And then if you have ambulatory withdrawal management services that you're offering, then that setting allows variability by members' level of need. You know, is it somebody who needs to come in every day based on what they're doing? Or if maybe I can see them today and I can do a virtual tomorrow, but then I want to check in physically the next day. And because we recognize that sometimes, you know, while withdrawal management doesn't necessarily go the full 10 days, once we go through that initial withdrawal, some of those psychiatric conditions start to surface. So we wanted to build in 10 days for evaluation and initiation of any medications, so that we are treating the individual's needs as they arise and setting them on the best path. And because again, ambulatory withdrawal management really is a nursing service, you have to have one NP or RN on site during hours of operation so that an individual that is coming in can get the care that they need. And so that brings us to, how do we go about developing this rate? Well, we looked at a lot of different sources. So we're looking at the 2022 behavioral health home rate. We're looking at recent main care rate studies. We're looking at the Bureau of Labor of Statistics. What are main care rates for physicians and behavioral health agencies? looking at utilization. We're looking at, information that we receive on our current health home providers. And we're going to be taking all of these existing rates and then factoring in, various clinical, programmatic, and input to then create a comprehensive rate model that will be shared in the future. Because again, remember, this is just the kickoff. So we're going to be looking at a lot of different sources to try and build out a rate model that is going to support success of this program. And so we are kind of, we want to hear from you. What are your current practices or concerns, or what is it that you're doing that we need to consider? And so by the end of the week, we will be sending out surveys, really asking you about types of SUD counseling offered, toxicology screening, mileage, staffing credentials. If you has our opioid health home providers, I know we've sent surveys out. So if you've already provided this information in the past, you can skip over that section. But we really want to hear from you. So we will be sending out that survey, and please, by all means, the more we hear, the better we can kind of create the model based on the needs of those clients who are coming to you, but then also what the agency, because we want to make sure that this is a model that agencies can successfully support.
And when saying that, if everybody could put if you are interested in filling out the survey and assisting us, could you put your email address in the chat? I know I can get it from Zoom, but it's also good to have that double backup in case we can't access it. So if you'd like to receive that survey, please put your email address in the chat. Thank you.
So next slide, if you guys have any questions or comments or concerns that you'd like to share, the next slide will have both Callie and I's email that you can reach out to us. If you want the survey, whatever the case may be, feel free to reach out at any time. Thank you.
So at this point, I think we could open up for any questions that anybody has. Feel free to unmute yourself if you have a question. I will stop sharing so I can see everybody. Christine?
Hi. So we do some level of ambulatory alcohol withdrawal management in one of the programs that I'm in now. And so it's great to see that it would be included for this. One thing that I have anecdotally observed in my participation in that is sometimes we'll refer a client from, say, the emergency room who needs this, and we try and start them. But I'm finding that some of the time they are reticent to start the counseling portion. And I noticed that with the SUD health home, that there would be a counseling requirement for the ambulatory alcohol withdrawal management. While I think that's good, in practice, I can see how that would be hard to achieve with some of the individuals. And so I'm kind of curious about how that would be reconciled.
So essentially it's a month-based model, right? So the first 10 days are really kind of focused on that withdrawal and what other physical health concerns are. And then at that point, it would be kind of like, hey, let's just meet with this person. Not necessarily like, hey, let's meet and let's do, tell me everything and let's start working on things. But just really building that initial trust and rapport during that withdrawal management level of care, because we recognize not everybody has come charging in the door going, hey, I want this, let's go. But we wanted to ensure that we weren't basically providing a level of care for a month, but not really starting that transition to the next level of care. And so that was our rationale for ensuring that counseling was required, just to start to build that trust to move into the next level.
Yeah. Okay. All right.
If anybody else has questions, feel free to unmute yourself.
Hey, Callie, I had a quick question.
Sure.
And just trying to understand how this new model either exists or doesn't exist in tandem with OHH?
Yeah, so basically what will happen is this will be encompassed into the OHH model. So what the standing model of what OHH is now is going to remain the same, and we're just adding additional levels of care or tiers within the model to encompass other services that people have brought up that would be helpful, also other diagnosis. So it's basically opening the door for a broader pool of people that need assistance with substance use treatment. Victor?
Hello, just a follow-up question to that one because that was on my mind too. Would we need to enter into an additional contract, or would this be sort of part of the contract for OHH?
Nope. So any of our current opioid health home providers will remain opioid health home providers, and we're actually just so you know, we're trying to keep the OHH theme. Like we want to keep the OHH so think of a different name that encompasses all SUD diagnosis, but we want to keep OHH. So any of our OHH providers are going to remain OHH providers. This will give an opportunity for additional providers to come into services if they're interested. This will also open up the door for smaller agencies that haven't been able to be an opioid health home provider because of the requirements of the staffing. There's availability for them to be able to come in because some of the levels of care doesn't require as much staffing.
Thanks, and Kelly, I might just clarify one thing too.
Yeah.
That this is the main care covered service for SUD health homes. So this is we're not saying right now that the uninsured side of the house that will have contracts covering all SUD diagnoses under this model for the uninsured contracts. Obviously, that's something we're considering with available resources, but right now we're really talking about main care.
Lacey?
Olivia read my mind, so that was my exact question. I just wanted to make sure if we were going to be required to do any of these changes or new things with the OHH uninsured models.
Yeah, we haven't got to that decision-making point at this point in time. But as soon as we do, I will definitely let you know. Because I understand that there are some providers on this call that only solely do uninsured services right now. So we will talk more internally as a team and get some feedback as well.
Okay, thank you.
You're welcome. Clem?
But just so I understand correctly, I just want to be absolutely sure. The contract model will still continue with OHH, and there is the regular SUD health home that at this point would be on only main care reimbursable.
As of right now, yes.
That's
we haven't
fine.
yes.
So
Yeah.
make sure we're not losing the other one. Okay, thank you.
Nope, you will not.
And I think it's an interesting question. Something we can be more clear on too is an opioid health home could continue to operate as today as remain an opioid health home and not necessarily expand to other services, other substances. I can't guarantee there will be no changes to the opioid health home model at this point, because some of these changes are just good practice to consider in the opioid health home model. But in general, we're not trying to necessarily change the opioid health home model widely. We're just saying if you wanted to expand to other substances, you now are able to, and then other providers might want to come in and start providing health home services, SUD health home services to that haven't already become an opioid health home. So multiple pathways, but if you're an opioid health home, you're going to basically keep doing what you're doing, and then the opportunity to serve more people and with different levels of care.
Anybody else have any questions? Kim?
Back in a few meetings ago, there was anticipation of the winter of 2025, maybe. Is that still kind of anticipated schedule?
So we're not absolutely sure of when the policy will be adopted, but it will be 2025. Is our 100% goal right now. Just not sure how quick, because the policy process does take some time. So it depends on the timing of different things, and there's a lot of clinical guidance going into our policy. So we just need to make sure we have all that feedback as well.
All right, thanks so much.
You're welcome. So Vicky, to answer your question, you would not require separate approval. If you're already an opioid health home provider, it gives you the opportunity to just, like Olivia said, do OHH services or expand it to all SUD services. So there's no different approval for this service. If you are a provider already, you're already a provider. And if any additional providers want to come in, they're more than welcome to reach out, and I would be happy to help you through that process as well.
It's essentially the same menu. We just added more options to it for you to choose. So it's all on the opioid health home. And then we said, okay, hey, you can also expand to take on this eligibility or offer these services.
Any other questions? Check.
Yes. I'm just wondering if there's, like, for different diagnoses, different substance use diagnoses require different counseling styles or techniques, or and if that's been sort of woven into the discussion around this.
I'll let Allison help answer a little bit because she's clinical.
So I think you're talking about like different modalities and like,
Yes.
So really in terms of the clinical components, all of the modalities are already basically allowed, right, within the component. The only thing we have on the table that is up for discussion to try and figure out that funding piece is the contingency management for stimulant use disorder. Anything otherwise like motivational interviewing, CBT, DBT, all of those that are already kind of offered. As a clinician, again, it's kind of in the opioid health home model. You might have a clinician that's like, I love motivational interviewing, it's the only way to go. And then you have another that's like, no, cognitive based. Every clinician has its own kind of, I guess, favorite. So that with that in mind, I think that we didn't necessarily need to change policy because that's already allowed. The contingency management is the only one that we are trying to figure out that incentive piece so that those individuals who choose to treat stimulant use disorder can offer contingency management and have support for that incentives.
I will say though, I think part of what's important when you all do a rate review, this is the rate determination process, is do some of those modalities or methods, should the rate look different for them? Like, does the rate that we present in the future cover the intervention that you would envision for the different diagnoses? So that's part of the challenge, I think, is like we need to be flexible because there's a lot of diagnoses that and co-occurring, multiple substances going on as well. So when you look at the rates, that is part of what you should be considering is, does this model, do the requirements fit what you would see delivering for someone with polysubstance or for a specific intervention?
Olivia, sorry. Go ahead, Chad.
It's kind of the way that it stands right now is that we're really only being reimbursed for treating opiate dependence. And now we're going to add alcohol dependence and, clients with multiple diagnoses that we have been treating along the way for that, but that it really hasn't been part of our reimbursement package. Just wondering if that might change.
Yeah, it's very good feedback, and thank you for that. And we can definitely look into that internally. And like Olivia said, the survey that goes out, there's spots for you to put additional comments. So I would strongly suggest if you do fill out that survey to also list that under the additional comments as well.
Yeah, just to cover the process a little bit. So the way we're envisioning this work, which is MaineCure, is a little different than how other rate determination processes work, where if you've been part of those, where you complete a spreadsheet about your existing model and how you staff everything and benefits and all those things. We're not going through that whole process again because we have very recent information about behavioral health services in general, but what we are doing is creating a similar framework where we'll share with you all the assumptions going into the model with draft rates and ask you to review those draft rates and the assumptions that led to them, so that you can parse out that question of, is this an adequate rate for the services you're being asked to provide, and then be specific, hopefully, with any feedback on, questions like, I see that you're building a rate that assumes an LADC, let's just say as an example. That's not necessarily true, but I employ this other type of, an LCSW in my practice for this. So that'll be the opportunity to kind of get down to specifically any assumptions that are built into the rate. And to Vicky's question, like, the policy may have may have a broader set of options than the rate. So, the policy requirements may be more flexible, but the rate has to assume one level in order to build it. So, or a blended level of wages to build a rate. So you'll see those kind of differences. We'll lay it out for, like, policy may allow for this, but the rate's built on this, and then you can judge from there.
So I think another question that was in here, does OHH currently reimburse for SUBLOCADE? So our model, our OHH model, does require medication prescribing, but our model itself does not pay for the medication. It is billed through a claim system through the pharmacy, or if you are giving the members medications right on site, then you can bill through your claim system for those medications. And SUBLOCADE is one of them, sorry.
Yeah, I wanted to make sure, because we've got this feedback a lot. Absolutely. Any type of medication for opioid health homes that someone needs to treat their opioid disorder is already allowed in the opioid health home model and is billed separately for main care. And then some people are confused about that on the uninsured side, which I'll let Kelly speak to if you'd like.
Yeah, sure. So for those OHH providers that have uninsured funding, again, it is covered up to $504 a month. So when we say $504 a month, a lot of providers, I'm sure you're aware when you're billing. So for tablets and films, it doesn't cost the $504. So that additional funding when we built the rate was to kind of cover those members that might need injections. This is something that we're always looking at. We're always looking at the rates of the medications and how much the medications cost. So it doesn't mean that it would never change in the future, the rate of what the medication is, but we do cover up to $504. And so those additional funds that you guys have for those members that it might only cost $150, that can be put into like a pool of money to cover someone that needs an injection. Will there be option to bill for drug screening separate from the bundled rate? So that is also something on the survey that we're asking questions about, and then we'll kind of convene internally and talk about that and like the results from the survey. So it is not off the table, but we still, from the data that we're collecting, will be able to help us determine a little bit more about if it should be included in the rate or separate. Any other additional questions? And I know sometimes it's hard, you think of something after you get off the call. So like Allison said, feel free to email Allison or myself. I can put both of our emails in the chat. Oops. And then we can go from there. And anytime you have a question or a concern or even just feedback, we value providers' feedback because that's what helps build the policies, because you guys are the ones doing the work. Olivia, really quick, would you mind explaining the process really quick? So we've had a bunch of people ask if we could have slides. And so my understanding is there's a website that the recording and the slides will go on, but I didn't know if you could explain that a little bit.
Yes. So these slides and the recording we posted on the Main Care Rate Reform website. So we're under the official rate determination process right now. And there's a wonderful website that has all the materials that will follow this process as we set the rate for this service. Perhaps Jessica could put it in the link in the chat. It's a great website for anyone who wants to know what's going on with Main Care rates. And we'll send out another listserv when any future meetings will be held, including the meetings to review proposed rates. So pay attention to your e-messages. Callie, I'm sure will also promote them to any provider that she already has in her Rolodex. And then we will keep you updated with along the way, but you can also check the website along the way. But for the survey, Callie is going to email it out to those people who have signed up to receive it, or if you're on the call today.
Yes, and for anybody from the department that does not see emails, for some reason the chat was set on only me receiving all the emails. So I do have everybody's email, so no worries there. And I just changed the chat not too long ago so everybody could see the questions. So I did receive them, so thank you. If there's no other questions, I will end this part of the meeting. And for anybody that would like to stay on that are current opioid health home providers, or even if you're not, feel free to stay on and join us. We have a few more things to cover, and then we'll adjourn the meeting for the day. So this is your opportunity. If you don't want to stay on any longer, feel free to sign yourself out. But if you do, then I'd be happy to have you on this call for the rest of the time. We'll just give it a few minutes for people that are dropping off, because I do see the number going down pretty quickly. So
I'm going to go ahead and stop the recording since we're in this piece.